quickly as we possibly can. So I'm going to provide some context. Joanna's going to provide a lot of detail around some of the projects that she's been involved with. We were really lucky that we were able to secure Joanna's time for a year, which finished in September, wasn't it, with us? And Joanna had the freedom to explore a lot of the data around the projects that we've got around non-conveyance to see what we're doing with it. So it'll become clear as we go through the presentation in terms of what we're trying to achieve. I do a few presentations and I talk to a lot of people and I try and ask them what they consider an ambulance service to be. And often people sort of framed their reference to television, and from a personal point of view, that happened to me too. I was a kind of a probably dull child and didn't go out much on a Saturday night, and it was family time on Saturday night, so we watched TV. And one of the popular shows that was on was a show called Casualty, and Casualty followed the everyday exploits of a bunch of nurses and, for me, significantly, paramedics within the NHS at the time, a little bit political on occasion, but it showed drama. Okay, it showed cardiac arrest, it showed stroke, it showed MI, it showed major trauma, it showed the glamorous end, if you like, and that's been reinforced more and more and more through fly-on-the-wall documentaries. So the overall view of the sort of the UK ambulance service is that we rush everybody to hospital, and we're in danger of modelling ourselves against that kind of behaviour. But I've got to say, from the point of view of being a paramedic and having done some work on HEMS, I've never ridden a motorbike, but it is quite exciting. But it's not the reality of what we do. The reality of what we do is more around the care that we provide for older people, okay? And as I progress through the service, I understand more and more and more that actually it's the older people that present to the ambulance service that actually they're the ones that we need to concentrate on more, because we're going to be able to do different things with these people. But actually, they're complicated, okay? They're not single condition presentations, as John was pointing out as well. So they're very rarely they're going to present with just a major trauma. If they present with major trauma, it's likely to be a fall, but what's caused the fall, okay? So we've got to get a bit smarter in terms of what we do. And we've got to try and get our paramedics to understand that complexity and be able to work in that kind of complex environment. So for us, in terms of community paramedicine, it's about, at scale, having our paramedics engaging with the community to try and prevent hospital admission in the first place. So, tell you a bit about North West Ambulance Service. North West Ambulance Service is one of, is it 11, Catherine? 10. Yeah, so yeah, 10 in the Isle of Wight, UK ambulance services, who deal with approximately an annual volume of 9,999 calls. North West Ambulance Service deals with about 1.15 million of those calls. When we break it down by age, we can see that actually the older end, I don't know if we've got a pointer on here, because I don't know if I end up pressing something that's going to whiz through 100 different slides. But anyway, 65 plus. Okay, these are unknown unknowns, 65 plus. So what we can see is that actually the number of patients that we deal with on a day-to-day basis, we look at about 50% of our workload is actually aged over 65. So you know, we've really got to work a bit harder around this. And what we can see is gradually there's an upward trajectory. Okay, so again, this links in with population demographics, where we know that our population is aging successfully. And as our population ages more and more successfully, and they get older and older, actually, and this is a horrible term, but it's bandied around a lot as burden. It's not burden. We need to adapt what we do to make sure that the care that we provide is appropriate for the people that are presenting to our services. So this is where we're at the moment, and this is what we know. For our patients that are aged over 65, we still take a huge proportion, and which is the proportion in blue, to the emergency department. We still do that. However, there is a significant proportion, probably about a third, that don't go to the emergency department. And we can break that down a little bit further. So the red in 20% of the guys that we treat on scene, so an ambulance will be dispatched, they'll assess a patient, and the patient won't go to hospital. We've got 10% where we get no A&E conveyance anyway, so they may end up going to an urgent care centre or an alternative to the emergency department. 3% would close with telephone advice. Okay, so 3% out of 1.15 million is a significant number, but we think we could probably do a bit better with that. And in 2%, actually, the caller cancels. Now, that'd be interesting to go into a little bit more detail in terms of that, but we haven't really got time to go into that in the presentation today. So really, within this, what we've got to try and look at is how we can move this. Probably 90% of the workload we do can be considered as urgent care, not true emergency care, but urgent care, so lower acuity, and how we can move our offer for paramedics more into the community and away from the acute hospital trusts, okay? And that's really what we're being asked to do. So what we're going to do over the next few slides when Joanna takes over is just try and demonstrate how we're focusing on this, how we can do it safely, okay? And that's one of the biggest challenges that we've got, is how we can safely not convey patients, all right? And it's about establishing for us as professionals a safety net. And we've got to, again, do it at scale with clinicians that range in their experience and levels of education as well, okay? We need to demonstrate how we're achieving this, and then more importantly, we need to take that as a baseline and then demonstrate what we can do to then improve. So I'm going to hand over to Joanna, who's going to take over from here for a short while.
Thanks, Duncan. So just what I'm going to do the first few slides to go over some of the projects that we've been working on. So the first thing that we wanted to do is look at what do we know. So we spent quite a bit of time looking through the literature, doing a scoping review to see what is out there. And we found that there's not much. So we had very, very broad search criteria because we didn't want to miss out on anything. And Duncan and I spent a considerable amount of time trawling through all of the articles. And of the 304 that made it to the sort of full text phase, we found that there was very, very, very few studies that actually looked at alternate routes of care. So we wanted to know, sorry, I guess I didn't say that in the last slide. We wanted to look at studies that deflected patients away from A&E or away from the emergency department. Some of the bigger areas, in the red balls here, were areas that we're looking at no option at all. But what we found was that a lot of them were looking at patients in A&E, how can they get them out of there? So as John just said, why are we trying to get the patients out of A&E when we can just not put them there in the first place? So there's a cartoon or a story of a stream, and people look up and they see people just floating down. So everyone's diving in, pulling them out, pulling a patient out, jumping back in, and it's nonstop. And one person decides to sort of walk away. But what he's actually doing is walking upstream, finding out why they're falling in the first place. So I think that's sort of a good analogy for what we're doing here, is instead of saying, okay, we've got a big crisis in A&Es, it's how can we make sure that doesn't happen in the first place? So the two green balls here that I have is the studies that we included in the systematic review. So there was 28 studies that looked at some alternate levels of care, and I separated them into two groups. One was evidence-based quantitative studies that I could actually sort of get something out of, whereas the other 18 was having the conversations. There's a lot of commentaries, editorials, discussions of policy. So our conclusion from that is that there is not much. There's very, very little research going on, and I think something like the International Roundtable is great because everyone's here is having the conversation, but the issue is that this isn't to say there's only 10 studies on alternate routes of care going on. They are happening, but they're not being published. So as a result, everyone is working in isolation. The work that we do, if we weren't to publish it, might get started from scratch because no one is sort of building and working together. So that's why all of the work we're doing, we're trying to publish, we're trying to share what we're doing so that other people can share back. So, Duncan.
So within NWAS, we're looking at three kind of current work streams at the minute. We're looking at our Paramedic Pathfinder, which I'll describe to you a little bit more. Joanna's going to talk to you about our GP AVS scheme. So GP is general practitioner, so that's a family doctor. And the AVS is our acute visiting service. So, and that will become more and more clear as the presentation goes on. We're also looking at self-care pathways for patients as well. So we've got a limited number of them, so a crew can go out, assess a patient, apply some clinical criteria to that patient, and then provide advice to self-care, okay? But it's safe advice. So it's not a clinician who's got very little education in discharging, making a decision that may be unwise. It's actually a clinically determined pathway that allows the organisation to say to a paramedic, this patient is safe to self-care at home. Okay, so Paramedic Pathfinder. As I said before, we deal with a huge volume of patients. We also deal with a huge volume of patients in quite a complex landscape of care as well. So within our health economies, we're subject to local variations and transformation projects. Back in 2010, we were challenged within the Northwest as our emergency departments in Greater Manchester particularly started to reconfigure. So the traditional model was we would have a lot of local accident and emergencies or emergency departments. Any paramedic could take any patient there. Okay, so there was no speciality in there as such. The health economy realised that actually this is quite an expensive way of running, and what they wanted to do was effectively downgrade centres and reconfigure them to urgent care centres. That led us to a bit of a challenge actually, because what we realised was, well, how do we access these places? How do we access the care for these places that are actually going to be more appropriate for a certain section of patients? So we had to have a bit of a think about this, and it's around about, for us, providing a means for our clinicians to navigate the system. So in order to navigate the system, we started to look and see what other triage tools were out there that we could use. One of the more popular tools that's used within emergency departments is called the Manchester Triage System, or the Manchester Triage Tool, which one or two of you may be familiar with. Manchester Triage Tool is a reductive tool based on 52 different patient presentations, okay? And you work through red flag symptoms down to amber flag symptoms, down to green flag, down to blue flag, okay? And as you work down, the patient is effectively safer to be left for a little bit longer before they get to see a doctor in the emergency department. That's how it's designed. So it helps stream flow within an emergency department. What we quickly realised within Paramedic Pathfinder was, within the process here, that Manchester Triage, with 52 different tools effectively, was very unwieldy. Okay, there was no electronic version. It was back in 2010. Smartphones were about. We weren't thinking about apps or anything like that at all. So we had it on paper. 52 different sheets of paper for each ambulance over the footprint of our trust is just bonkers. So what we did was we worked really hard and got a team together, and we streamed it down. So we've got 2 Pathfinders. We've got more, but mainly there's 2. One for trauma and one for medical presentations. So essentially the clinician arrives at scene, decides is this a medical presentation or a trauma, and follows this reductive flow chart. There are certain exceptions. So we've got specialist pathways for stroke, for MI, for major trauma, for maternity, mental health, and so on. But for the majority of the patients, they will fit within the Pathfinder, and it allows the crews to determine whether the patient is going to go straight to the emergency department with a little bit of intervention, whether there's a bit of time to stop and think, and then determine whether that patient might be more suitable for an urgent care centre. As we developed this, what we began to realise is the patients that we were streaming off towards the urgent care centres, we could do something different with them as well, okay? And the things that we could have a look at a little bit differently was actually, instead of transporting these patients to a place, was there a way by which that we could engage those patients with a community offer and maybe with a general practitioner or family doctor scheme? Okay, I'm going to hand over to Joanna again.
So just a bit more overview on our AVS scheme. So how this works is, as Duncan was saying, we're following the Paramedic Pathfinder tool. Some of the patients will be flagged as amber, so these individuals don't need to be conveyed blue lights to the emergency department, but they don't meet the requirements to stay at home. So there's a huge proportion of these patients that are sort of finding a medium for these non-emergent but still requiring medical care. So what we have is the GP referral scheme, where the paramedic, if they decide that the patient should have some level of care but not necessarily adding to the overcrowding in emergency departments, can be referred to a GP. So there's a car in every a phone in every ambulance or in every car, and they will just call the GP, and through a clinician-to-clinician handover, the GP can decide to accept that patient into care. So sometimes the GP will go and visit the patient. Sometimes they might prescribe something on the phone or do sort of a over-the-phone assessment. So of the in a 12-month period, there was over 50,000 attempted referrals. So at the end of the day, it is the GP's decision whether or not they want to take responsibility and accept that patient. The majority of them were accepted, so 90%. So this is 50,000 patients in 1 year is a huge amount of people. And this, I've put some of the numbers here in what the tariffs would have been, the number of bed days that it would have taken. So there's quite a few direct and indirect costs that are saved here. And the important thing is to remember that these patients, these 50,000 patients, would have been conveyed to A&E because they weren't safe to be left at home if this scheme wasn't in place. So the first study that we were doing, we wanted to look at these patients. We wanted to follow their pathway and decide, is it safe? Because these numbers are great. If we're looking at 25 million pounds, that's great. But at the end of the day, if it's not safe for the patient, there's not much benefit from it. So we were originally planned to look at a cohort of 10,000 patients, following them throughout. We had a bit of a nightmare trying to get data, so instead we ended up with a smaller pilot study. So that PowerPoint conversion thing is giving me an issue here as well. So we looked at patients in the Salford Royal Foundation Trust. So this is just a defined area where most of the patients would go to this hospital within the area. So we divided them into 2 different cohorts, and this is over a 3-month period. And I'm not sure if you can see those numbers there, but it was about 4,000 that were conveyed directly to the emergency department and 300 that were referred to the GP. And I'll come back to that flowchart in a second. So some of the differences that we found was that on average, those who were referred to the GP were older, and we expected that because of the comorbidities, that people that might be calling were dealing with medical conditions that they were perhaps used to self-managing and maybe needed a GP rather than a more sort of acute reason for a phone call. And they also tended to be more likely to be female, and then the reasons for the call was quite consistent with the Paramedic Pathfinder tool. So those who were referred to GP were meeting the amber flag, so things like non-traumatic back pain, diabetes problems, the general coding of sick person, whereas the ones who were conveyed directly to the emergency department were slightly more problematic and time pressure for that. So we had hospital data. Of the 4,000 in one group and 300 in the other, we wanted to look at 150 within each. Obviously, there were some issues with missing data and the patients not being tracked properly, but we approximately were able to find these numbers. So of the 143 patients that had been referred to the GP in a 3-month period, there was only 32 that presented back to A&E within 30 days. So that 111 patients were successfully deflected from the emergency department. So for us, this was quite positive because these patients would have gone into hospital, potentially staying a few extra days, bed rest, and might have actually come out more ill than they were when they first went in. And then we did a little bit of analysis in comparing the groups. So I just mentioned the hospital admissions. We found that there were some characteristics of those who were referred to the GP. So again, the comorbidities are more likely to have some type of long-term illness. And then I did some regression modeling and looking at mortality outcomes. There was a 6-month death within the first 6 months. So those who were conveyed directly to the emergency department had about a 2.5 times higher chance of dying compared to those who were referred. This is probably driven by the reason for the call, so likely more emergency. It could have been stroke or cardiovascular related. However, what we found to be quite interesting is that there was actually no difference in mortality risk between those who were conveyed in the first place and those who'd shown up those who had shown up within the next 30 days. So that significance in the earlier result was probably driven by by people who did not actually need to go to the emergency departments, the ones that had been successfully referred back into the GP, to the GP. And then we also did sort of a rough cost analysis just to compare the potential of savings, and we found that it was more than double just to be conveyed to the A&E. And these are ambulance costs. This is not even taking into consideration how much it's costing in the emergency department, how much the prolonged hospital stay is costing. So I've spoken about this scheme and how great we think it is and the potential benefits of it. But at the end of the day, it's the paramedics that are out there that are deciding to triage the patients back into the community. And if they're not going to do it, then there's not much point in having the framework there. So what we did is a small observational study. So this was one of my favorite projects because I got to go out with paramedics, ride along, observe them, talk to them, and get their opinion. And I learned a few things, one of which paramedics are very interesting people, and I'll leave it at that. But we did some qualitative analysis, and 4 major themes emerged. So the first was about approaching the patient with the scheme in mind, and we wanted to see, before you get to scene, when it pops up on the screen, do you know what you're going to do already? And we were hoping that, the paramedics were not going to decide a priori, and that was what we found. So indeed, the paramedics are going there, they know that this framework exists and they have this possibility, but they're not trying to stream 100% of the patients there into that, back into the community. So they're still gonna go, they will do their job properly, they'll triage properly, and only refer those that need to be referred and those that are safe to be referred. The next thing we found is that there was quite a few barriers to GP referrals, and the paramedics talked about a lot of their frustrations. So one of the main frustrations was the process itself. So how it works is you call the GP, and they're not going to pick up right away, but they're supposed to call back in, I believe it's 20 minutes? In 20 minutes. But any of the paramedics will tell you that doesn't happen that quickly. However, what we found to be really interesting is that the paramedics don't mind waiting, and sometimes they're waiting up to an hour to get the call back from the GP. They don't mind waiting if the process is done properly. So if they wait for an hour and the GP rejects the patient and makes them take them to A&E, that's going to discourage them from referring in the future. However, regardless of some of the frustrations with it, if they're still getting the patient into the community and doing the right thing for the patient, for the healthcare system, they're happy with that. So that sort of leads to the third point, which is the barriers and the frustrations with the GPs themselves. And there was a lot of sort of pushback from the paramedics who asked me, well, are you going to go talk to the GPs? Because the problems aren't with us, the problems are with the GPs. So it was an important point, and something that we want to explore a little bit more is getting all sides of it. So like I said, we've done the numbers, we know that there's benefits of it. Do the paramedics want to do it? And now, are the GPs receptive to it? So there's quite a few barriers. I won't go into too many details about this, but I've put our publication there. Again, we're trying to have the conversation and get that out there, so it's a bit more detail. And then finally, the paramedics discussed sort of the awareness of the scheme. So I was able to go in as a non-paramedic and pretend not to know anything about ambulances, so I could listen to the paramedics tell me everything, which was great. And what a lot of them reported is that they knew the scheme, but nobody else knew it as well as they did. So it was an interesting finding, because what we sort of take away from that is that it's very, very important that the paramedic is understanding how the scheme works, understanding the times, understanding the referrals, hearing back from the GP. So some paramedics will go in, will make the decision of what happens to the patient, convey them or refer them, but they have no idea what happens afterwards. So some of the paramedics were getting phone calls from the GP saying, thanks for calling, I went to see that patient, this is what happened, it was a great decision to refer him, exactly what he needed, let's do this again. And I think some of that feedback is missing in terms of encouraging the paramedics to continue.
Okay, so in terms of what the work tells us, it starts to tell us and give us some intelligence to base our sort of structural and organisational decisions around. We know that the patients that are referred are mostly old. We know there's a greater possibility with an older population that they're going to be frail. Okay, so we need to be able to organise our workforce around that. We know that of the 1.15 million patients, about 500,000 of them are over 65 years old, and we know that there's an increase in the numbers with the oldest old. But what we've demonstrated is that there are definite opportunities there to prevent avoidable harm by admitting people to hospital. We know that for older patients, when they're admitted to hospital, they're at increased risk. They're at increased risk from hospital-acquired infections. They're at increased risk from falls. They're at increased risk for delirium. Increased risk for delirium will lead to falls, okay? So there's a big bundle of harm, actually, that we're aware of, and that happens in hospitals every day, that actually we have, as paramedics, the opportunity to try and prevent, okay? So and this is where this work really, really starts to come into its own, I think, because when we start to understand what the risks are, then we can start to do something a little bit about it. So when we start to talk about a community, our community could be defined by a community bounded by age, okay? So rather than having a discrete geographical community, we might be thinking of age as our community within the North West Ambulance Service. As we're doing that, what we need to understand is we need to understand a little bit more around the aging process, a little bit more around dementia, and a little bit more around frailty as well. And what we're looking at is perhaps a three-stream means of triaging patients to enable a much safer approach to them. So are they physiologically safe? So physiologically safe we can determine by using the Paramedic Pathfinder because it's a physiologically determined tool. Okay. We need to determine whether they're psychologically safe, and within psychological safety we're looking at screening for delirium in particular, because a new acute onset of confusion can lead to other things, but they don't necessarily need to go to the emergency department. But if we can flag delirium, we can put things in place within the community to enable somebody to have effective and bespoke care at home. And then what we're looking at is functional safety. And I'm going to hand over to Joanna again, because Joanna's done a really good piece of work about looking at functional safety around sort of frailty.
So this is this is the pictorial fit frailty scale. So this was developed by Ken Rockwood, who's a geriatrician based in Nova Scotia. So we look at frailty as a construct rather than as an adjective, as a descriptive, oh, she's frail, she appears to be frail. We wanted to define it. So there's a few different measures of frailty that are used in research and in clinical practice. But this pictorial scale was developed because of how easy it is to use. There's no issues with language. There's no issue with sort of education level. You look at the pictures and you decide which one it is. So this can be filled out by the paramedic. It could be filled out by the patient, by the carer, by the GP. And I'm not sure how well you can see it, but there's 2 boxes below each image, which is current and 2 weeks ago. So if we were looking at someone's frailty score at time point A, but we have no idea, or sorry, at time point B, but we have no idea what their baseline is, we don't know if there's sort of reason to be concerned. So we haven't quite figured out how to score the frailty. We haven't validated it yet, but if you're looking at a score, and if they have a frailty score of 40, which would be fairly frail, but normally they're at 20, then that's problematic. But if you're visiting someone who might be 95 and they have a score of 40, but they've always had a score of 40, that might be their baseline. So what we wanted to see is the scale, which is in the midst of being validated and has had some positive feedback in Canada, is could this be used in practice? So again, it's something that works, but will it work with paramedics? Are paramedics open to using it? So we did a few different parts. The first part is that we asked the paramedics to think of somebody that they knew, could be a patient, it could be a friend, and answer a few questions on them and fill out the frailty scale. So part A, so along that axis there is the frailty score. So this is I believe there was just under 200 paramedics that answered. So they filled out the score for someone they knew. So all these people are different. But what we found is that the characteristics of this scale were the same as you would expect of frailty. So there's slightly higher levels of frailty in female. Frailty obviously increased with age, and that the frailty score was consistent with their sort of the reported health status. And then in Part B, we gave them a case study of a potential incident that they could arrive to on scene, and we asked them to fill out the scale again. This time, it was for the exact same patient. So what we found is that there was very, very high validity of the scale. So if we look at all the different domains that I had shown before, we wanted to make sure that the scale is working. So if one paramedic is giving them a very high mobility score and the other's giving a low one, obviously it's not measuring what it's supposed to be measuring. But what we found is that it was. So if you look at the second column, which is the percent with the same or within 1, so to the left or to the right of each, it's nearing 100% for everything, which is great. So one, the scale from paramedics is consistent with characteristics of frailty. 2, it's internally the inter-rater reliability is high. And then the third is we wanted to know, do paramedics want to use this? Will they use this? Is it feasible? Because it does take time to fill out. It doesn't take much. It can take 5-10 minutes, but it does add to their assessment. And we got quite positive results. I don't want to walk over because you probably won't be able to hear me. But again, the majority of the patients or the paramedics thought that it was feasible and was useful. And we asked them who they wanted to fill it out. If they wanted to fill it out, if they were comfortable giving it to the patient, or if they were comfortable having sort of a third party there. And most of them preferred to fill it out themselves, but you'll see from the numbers, so if you look at the third and the sixth line, so feasible to be completed by, the second and the fifth, feasible to be completed by patients, 68 and 70% is still quite positive. So that's that. So sort of our takeaways from this, there's my, our takeaways from this is that we've got a scale that measures frailty that's reliable amongst paramedics, and paramedics want to use it. So some of what we're hoping to do in the future is to look at it, and Carol, who presented yesterday, is also interested in that, and taking the scale now. The next step is to go into the community and to use it, and to add it to the patient assessment, and then we can start to look at things that might predict being admitted to hospital or calling an ambulance and that type of thing.
So as we start to sort of sum up where we're at in terms of looking at what we do next, I think it's really important that for an ambulance service or for a paramedic service that we establish a very well-led work stream for older adults, which incorporates falls, frailty, delirium and dementia, and what I've not put on there, which I needed to have done, was end of life too. Okay, we're changing and our patient load is changing. We concentrate a lot on cardiac arrest, we concentrate a lot on resuscitation, major trauma and so on. And we need to be experts in that area of practice that differentiates us a lot from other healthcare practitioners. But we need to be able to give our workforce the skills and abilities to be able to go out and effectively provide care for the majority of our patients, actually. Okay, cardiac arrest within the UK represents about 0.6% of our activity. Yeah? If we look at 50% of our activity being over the age of 65 and the unique challenges that they provide us, then actually the weight behind that is actually far stronger. If you talk to university departments, they're very much geared towards giving new candidates on diploma programs the skills to deal with the high acuity incidents. We need to challenge the universities a little bit. We need to challenge expectations. And I think if we've got some really well advertised and well led work streams that take that into account and have older people as our community, I think that we'll start to move the profession in the direction it needs to be fit for purpose for the next 20 years. One of the things we need to do next is engage more with research. So as Joanna said, we've got community specialist paramedics that are looking at the pictorial fit to frail scale. So that's the third point. But we also need to look at validating the pictorial fit to frail scale for use within paramedic practice within the UK. So there's been an awful lot of work done within Canada, which is fantastic. We need to build on that because the population and the systems and the dynamics and so on between the two countries are probably sufficiently different. There's commonalities, but probably sufficiently different to make sure that we need to ensure that what we're using is equally validated for our practice. And it's a new thing as well. We don't tend to in-house validate academically what we do, okay? So from the UK point of view, we need to really push the research agenda forward. We need to use our community specialist paramedics more effectively. I know there's challenges around that with funding, which James and Carol highlighted yesterday. But again, for those guys to use the visual or pictorial fit to frail scale as a baseline for the patients that they'll see on a daily basis, that's a fantastic piece of work. Another part of the work that they're doing that Carol probably described yesterday was around the care home project. We know that an awful lot of patients present to us from care homes, and sometimes they present to us because the people that work in the care homes, through no fault of their own, don't have the tools to be able to make a nuanced decision as to whether to ring 999 or not, and they don't know how to navigate the health systems. They get somebody who does. Well, if we can help them navigate, actually we can help to prevent calls in the first instance. I'll talk about that a little bit more later. We've also got within the North West Ambulance Service a scheme with collaborative cars as well. And what I mean by that is we have a fast response car, or a not so fast response car, with a paramedic on board, but they're dual crewed even. And the person that sits with them is either a physiotherapist, an occupational therapist, or a nurse practitioner who has expertise in providing the secondary prevention advice and the exercises and getting stuff ready for falls. So the collaborative cars that we've got at the minute are targeted towards older people that fall, that form a significant proportion of the work that we go out to. So within that, we look at the secondary prevention. We can't prevent the first fall, it's already happened. But what we can do is put systems in place and effective tools in place to stop the second, third or fourth fall that might lead to significant injury, fractured neck or femur and so on. So that's what we need to do next in terms of that. Where are the Welsh guys? Do you recognise this? Huh? Yeah, the guys from Wales may recognise this because this is what we're looking at for our sort of the main aims for our clinical strategy. And the aims for our clinical or our patient care strategy for the North West Ambulance Service have been borrowed significantly from the work that's been going on in Wales. And I'll explain why. The framework that this provides allows us to look at how we can prevent hospital admission, okay? And how we can prevent additional burden on the 999 service, which allows us to use our resources far more effectively to benefit local communities. What we're looking at is a shift to the left. So what we've got is a traditional trajectory from a call to making sure the right care gets to the patient, making sure that we provide the right treatment for the patient, and then direct them to the right place. So traditionally, that trajectory would be 999 call, out goes a paramedic, they provide some treatment on scene, and take them to hospital. Okay? That's our traditional practice. We want to challenge at each part of that and actually shift left as far as we can to prevent the next step. Because what we understand is, through some of the work, and particularly with the older patients, is that the more the patient goes further down the trajectory and ends up in hospital, the greater the chance that they're going to be part of that system for a long period of time. You've heard on the news about our problems with delayed transfers of care. So if we can try and prevent that by preventing them going to the hospital in the first place, but we need to act collaboratively as part of a much, much bigger system. As we do this, and as we step each part backwards, we start to look at what happens before the call. And this is the work that Carol and her team have been involved with in terms of working with the care homes to prevent them from calling us in the first place. Our high-intensity users, such as the police, some of our frequent callers, all that stuff that we can bundle up within the local community. And so a lot of the work that Carol's been doing is around educating healthcare professionals about when to use the ambulance service. We can really concentrate on pockets and pockets and pockets everywhere. And then at scale, what we end up doing is actually reducing the burden on the ambulance service, which then means that we can use our resources far more effectively, okay? We're getting an increased number of 999 calls each year, but we're not getting a commensurate increase in resource, okay? So we've got to think smart, not work hard, okay? So that's part of what this whole process is. So in terms of delivering the right care to the right place, actually we need to be far more effective at preventative stuff than we currently are. And a lot of the work that Joanna's been doing for us helps us to understand. It helps us to understand what the paramedics think about what we're providing them with, which we think are a good thing to help, But actually we need to understand the barriers, because ultimately it's the guys at the pointy end that are delivering care that we need to engage with all these processes. So the observational work has been absolutely fantastic. We need to know about how effective the referrals are. We need to know about the recontact rates. We need to know about the savings that we make the system as well. So what we're looking at is working at scale to actually provide bespoke care to patients within those communities, but allowing all of our paramedics to act as community paramedics. And that's where I'll leave you. Yeah, that's it.
Complete culture change.
Yeah.
And transformation from the blue light to this is our process. That's what we're here for. We are doing patient care.
That's it, yeah, and it is all about patient care, and it is, we're very, very guilty of that sort of, you know, that heroic kind of complex of we're paramedics, we're here to save you from your cardiac arrest. Well, on average, a paramedic will deal with 1 or 2 cardiac arrests per year. So the skill set there has to be maintained. We've got to think different ways around that, but actually it's around the majority and providing that bespoke care within the community that will allow that patient to remain where they are safely, and the key is around safety.
And you're then or still doing it?
I'll take that. Thank you.
Great presentation. Question, so you mentioned the increasing call volumes. The resources kind of stay the same. And I'm wondering about that extended on-scene time that you have during the GP referral. Does the up to an hour or more, I think you said?
Yeah.
What impact does that have on the resources?
We've done some work around that, and the work the study around the overall sort of unit utilization hours, which is the time spent from sending the vehicle out to actually coming clear. It's actually, on average, for the GP referral scheme, is 15 minutes shorter through going through that whole process than actually transferring to the emergency department. Because the context that we're in at the minute is that ambulances are routinely being delayed at the emergency department because there's no capacity. So actually, whilst it might be slightly painful to be on scene for an hour waiting for a phone call from somebody, actually that's probably an hour very well spent, because within that time there's a lot you can do as a paramedic, and as we're all aware, as the clinicians in the room, you're not just sitting there having a natter and making tea. You're constantly looking around and thinking, actually, and you're building a big picture, and that big picture that you're building is what you're then doing with a clinician-to-clinician handover. So in the overall scheme of things, yes, it's a long time to wait, but actually, when we look at the bigger data, it suggests that even that longer wait in the overall scheme of things, we're getting benefits from that. So.
Thanks both for the presentation. It was really interesting to see the innovative work. Certainly the frailty work is very timely, and at the ALF conference we had the DH lead for frailty explaining much the same detail, Martin Vernon, so that was great. Paramedics in the UK, or England certainly, have been traditionally quite good at discharging patients on scene, often at their own risk rather than at the corporate risk. I think the introduction of the Manchester triage provides a really useful framework for that. But we are still quite unique in the way that our paramedics run, that we do expect them to be taking these quite high-level clinical decisions. Is that sort of tool the way forward, do you think, to sort of add a safety net underneath the clinical decision-making? Because we're investing an enormous amount in their education in the first place. That sort of tools, you know, technician level, follow this algorithm. Do this and you'll be fine. But with a paramedic who's educated and the rest of it is following an algorithm restrictive rather than helpful.
Yeah, it can be. So for our new entry clinicians, we will expect them to use Pathfinder because it's safe. They know where they're up to. So our EMTs, we'd expect them to use Pathfinder. We're looking at a scheme of clinical delegation at the minute. And within the scheme of clinical delegation, we're linking that to levels of education. And it may be that the more education that you get, then you can start to unpick parts of Pathfinder that you're comfortable because you know, and you've got the education to back you up to make the decision. That's in isolation, but we should never be making complex decisions in isolation. So what we've worked really hard with in the North West Ambulance Service is having a very clear model of clinical leadership. We've got 42 advanced paramedics, we've got 6 consultant paramedics, we've got 4 medical directors within a medical directorate, not all full-time, and we've got a clinical support hub, or a trauma cell with 24-hour cover with an advanced paramedic. So our clinicians on scene, if they're coming to the point where they're making a decision and they're thinking, if they're thinking, then it's time to have a chat. And what we're encouraging them to do is spin it up the ladder, to have a discussion, to provide them with that little bit of a safety net and a little bit. They've made the decision ultimately. Most of them have made the decision of what they want to do, but it's just that little bit of confidence they need to actually do it, to pick up the phone. So yes, Pathfinder can be restrictive, but from where we were, we didn't have the education initially to be able to make the decision to not convey patients. That's where we came from. And my paramedic course was 4 weeks theory. This is after 2 years of being a technician. 4 weeks theory, 4 weeks in hospital. It's the old IHCD. And then at the end of those 8 weeks, I was a registered professional. It scares the bejesus out of me that after 2 and a bit years, with a technician course, some experience, and then that paramedic course, that I was allowed to go out and play with patients. Yeah, I've obviously supplemented that a little bit now. And that was our baseline. Yeah, and we had an awful lot of clinicians that had an awful lot of experience, but we didn't know whether they were making the right decisions until we started to get the complaints and the coronial inquest and all this sort of stuff coming in, which were the warning flags at the time, which led to our medical director, our previous one, Kevin Matway-Jones, when he came into post to say, right, this is how we're going to do it now, and we're going to build. And we've built, and we're at a stage now where Pathfinder's served a purpose. And I think we're at the stage now with certain of our clinicians where Pathfinder will restrict them.
I think that's useful for this sort of audience to know that that's not the complete package, and that's what you get, and that's what you do. It's part of the bigger picture.
Yeah, definitely. Yeah, it's difficult to get everything in a presentation in this time. So yeah, thank you.
With just under 5% being referred to your GP, did you have any adverse outcomes of any of the patients that significantly rose, that your risk management people, your attorneys had problems with?
We have, but the numbers have been very, very small. And when I say very, very small, perhaps on the fingers of one hand where we can count patients that have died. When we've investigated that, actually the decision and the clinical handover, because these are done on taped lines. So the whole purpose of this is we've got a strong governance trail, so that if there is an issue, we can trace the calls back, listen to the calls, listen to the conversation, look at the paperwork that the paramedic leaves and so on. The decision, sometimes by the GPs, was not to attend, and they attended outside of the 2-hour window. So the initial way it was set up was, so they took the risk on, and it was ultimately the decision that the GP had made. It wasn't the ambulance crew, but it did worry the ambulance crews when we said, right, we're going to have to talk to you about what you've done. Because it can only take 1 or 2 of those to rapidly fire through the mess room, and all of a sudden, all the brakes are on because somebody's been hauled through the coals for something that's not necessarily their fault. So yeah, so we have, but the numbers of adverse incidents are tiny. It is very safe. It's been set up deliberately to be perhaps too safe.
Will you be publishing that end of it?
This is the one thing that I want to work on. My role is quite new. I've been in post for about 15 months. One of my roles is to head up R&D. We've only just launched, say, a research strategy, and part of that is around dissemination. Traditionally, as an ambulance service, we were very poor at disseminating our results, so I think we need to be better at that, okay? And I don't think we're unique in that respect. There's a lot of really good work that goes on in UK ambulance services, loads and loads and loads of it, but you don't hear about it unless you talk to somebody at an event like this. We need to get better about that. So I can't make that promise, essentially, is the answer to that one. That was evasive, wasn't it?
Thank you guys very much.
Welcome.
So